Assalamu alaikum. Good morning, everybody. I'm Dr. Hussain Ebrahim. I'm a consultant pulmonologist. I work in Salmani Medical Hospital in the mornings and recently joined the BSH family from last month on a part-time basis doing 3 clinics. I do most of the scope of the pulmonary cases, but with special interest in sleep apnea, interstitial lung disease, and asthma. So this is my first presentation here. I chose pulmonary embolism as a first topic because I think it's an important topic and it's quite prevalent actually, as you will see. And I think there's a piece in it for everybody. So whether you're a surgeon or you're an oncologist, hematologist, somebody dealing with obese people in the endocrine, you are likely to encounter, or more likely than not to encounter, cases of PE or missed PE in your practice over a lifetime. So it's not just the pulmonologists who are doing the screening and service now. We want to promote more awareness amongst the, let's say, the other colleagues as well. So we'll proceed with pulmonary embolism presentation. It's going to be based on the latest guidelines from the European Respiratory and Cardiology Society, 2019. So this is our agenda. We'll talk about the diagnostic algorithms and how to go about suspecting and then investigating. Then we'll go through the classification, what we call the PE classification and prognostication. And this is followed by discussion about few trials that are practice changing. And then we sum up with a little bit of treatment, risk of PE recurrent, and how we follow the PEs. And then a small new concept called PERT, which we will go we'll discuss about. So as I said, the last guidance we have is from 2019. We're expecting new guidance probably this year or next year. But as of current, this is the guidance we're applying. And as you can see, it's a big group of our task force really of members. And all throughout this presentation, we will use this nomenclature. So if I mention any recommendation, you'll see a class 1 or a class 2 or a class 3 in front of the recommendation and the level of evidence. So if you say that the recommendation is class 1A, that means that we recommend to do this action, and the level of evidence is very high. It's coming from multiple randomized controlled trials. I think this is quite standard and probably most people already know this, but it's just the key for this presentation. So as I said, this disease is quite prevalent, and when we compare it with things like MI, heart attacks, strokes, CNS or CVA and such, it's actually third in line in terms of commonness. So if we take incidence and prevalence in the States, for example, there's approximately 115 cases of PE diagnosed per 100,000 of the population. So if we want to apply that to Bahrain, let's say we roughly have around 2 million as a population. We're talking about probably 2,000 cases per year of diagnosed PE all over Bahrain. So that's quite a big number for a small country like Bahrain. And not only is it prevalent, unfortunately, despite improvement in diagnostics and treatment, it still is quite a burden in terms of mortality. So we have in the States, that is once again 300,000 people die annually of pulmonary embolism. Yeah, so that's quite significant, and a little bit more in Europe, actually, almost 400,000, and that's back in 2004. However, things are changing fast, as you know, we learn from studies, and there are more resources and treatment modalities. If you see this graph on the left, we're talking about the incidence. So as you see in the States, Italy, Spain, worldwide, the incidence of PE is going up. However, the graph on the right is showing the opposite in terms of case fatality rate. So we are diagnosing more PEs, but we are saving more lives because the mortality of PEs is actually going down. And if we take China as a stark example, back in 1997, the death rate was almost 25 per 100 PEs. In 2009, it dropped to around 10 or 11. And obviously the States and elsewhere in Europe, they're doing even better. Okay, so we are diagnosing more, but we are saving more lives, which means we're going in the right direction, but there is still margin for improvement. So when we suspect a PE in a patient who walks to your clinic or to the emergency, what do we do? Do we depend on, scoring criteria? Do we depend on certain signs and symptoms? It's actually a constellation of all. So what the guidance suggests is that we can use validation prediction rules, and we can use labs like the D-dimer, and also clinical gestalt or clinical probability. And we'll see how. So the ESC 2019 guidelines, this is the framework they use. So if you see a patient anywhere, as I said, in the clinic, but usually in the emergency coming unwell, and you're suspecting pulmonary embolism as one of your differentials, you need, as a clinician, to classify whether you think that the probability is low or intermediate, in which case he will be on this side of the algorithm, or you think that genuinely this patient actually does have a PE from the get-go. Before doing anything, I do think that this patient will end up having a PE. So that will be a high clinical probability. And probably for people not working with PE, it's probably difficult based on your experience to say low. How can I say this is low, intermediate, or high? But that usually goes to the pulmonologist or the ICU doctor to start with. However, this is not a singular method. This is the clinical probability based on your experience and suspicion. We always supplement this, according to this guidance, with prediction rules, and we will see some of the prediction rules now. So there are, certain criteria that we look for, and these increase or reduce the odd of PE. Now, after you combine your prediction rules and probability, if the probability remains that PE is unlikely, you go for a D-dimer. If the D-dimer is negative, that's the end of story. This patient is very unlikely to have a PE. However, if the D-dimer is positive, you will proceed with the diagnostic modality, which is a CT pulmonary angiogram. On the other hand, if your clinical probability from the beginning is a high, that you do suspect that this patient is having a PE, and the prediction rule is also in line with that, you really don't need to bother with ordering a D-dimer. Just go directly to the CTPA, because you don't want to waste time. This is, as I said, patient could be hypoxic, about to collapse. You want to just, reduce the wait time until treatment. Also, D-dimer, even if it's negative, even if we put D-dimer in this arm, and if it's negative, but my clinical probability as an expert or a pulmonologist is high, I will not believe the D-dimer, because it's proven that it does not exclude PE anymore. So this is the first message from this talk. D-dimer is correlated to your clinical probability. Now, and what level of evidence of that? As I said, 1B, so use of validated criteria for diagnosis is recommended. So this is a recommendation which we should do. And also, they say once you suspect PE and you're going along the right side of the pathway, you should initiate anticoagulation without delay. So that's a 1C. So that's an expert opinion, but still to be taken in mind. So what are the validation prediction rules I told you about? There are several. Probably some of us know the Wills criteria or the Geneva's criteria, but there's more talk now about the Years algorithm, which comes from the pregnant cohort, and the PE rollout criteria. So the PE rollout criteria, as the name indicates, it's when you don't suspect, or you suspect that PE is low on the list. It's an 8-point scale. If all of them are absent, then you can fairly stop there and say this is not PE. So if you're thinking that PE is a low probability and all the 8 points are absent, so the PE rule-out criteria is 0, that means we can stop. We don't need to do dimer. We don't need to do anything. However, if any 1 point of the 8 is there, then unfortunately PE rule-out criteria don't tell us anything other than we cannot rule out PE. We have to investigate further. Okay. And then a word about D-dimer. As we said, we don't use D-dimer singularly. We use it in the context of clinical probability and prediction rules. And also there is talk about age-adjusted D-dimer. So as you know, in the classic teaching, we used to compare the D-dimer with the reference range of a given lab. If it's higher than the reference range, then that's a positive Y. But that's probably second best. Now, what's more recommended is to correlate it with an age-adjusted D-dimer for people above 50. So once you're 50 or above, the D-dimer should be above your age multiplied by 10. So if you're 60, it should be above 60 multiplied by 10, so 600. If it comes as 550, it will still be counted as negative for that age. Now, what is the Years algorithm? As I said, this is adopted from the pregnancy, really, but now we can also apply it to non-pregnant people. So it's a 3-scale criteria. Either you have clinical signs of DVT, hemoptysis, or PE, which you think is the most likely diagnosis. If any of this is available, is there on the list, so tick 1, 2, or 3, then you're on this side of the pathway. You do a D-dimer, and the cutoff here for the D-dimer is 500. So below 500, you exclude PE. More than 500, you proceed with a CTPA. If none of these criteria is there, so it's a 0 years score, the D-dimer cutoff is higher. Instead of using 500, you use 1,000. And once again, if it's less than 1,000, then you rule out PE. If it's more than 1,000, you need to proceed with the algorithm. So this tells us that D-dimer on its own really means nothing. You need to correlate with the age. You need to correlate with risk scores such as the years score. And as I said, this actually originally came from the pregnant people. So because back then, they wanted to, firstly, we know that the dimer goes up in pregnancy. Okay, so that's nothing we can, depend on. And also in pregnant people who are suspected of having a VTE, we used to like to avoid CT pulmonary angios because of risk of contrast and breast cancer and contrast to the fetus as well. So they adopted this for the pregnant lady. And, once they have one of these points, especially clinical signs of DVT, the recommendation in a lady who's pregnant and suspected of having PE was actually to do a Doppler ultrasound. And if it's positive, we treat as if she also has PE. If it's negative, then we go to the normal years algorithm and see once again whether she has one or more of these criteria and use this cutoff of D-dimer, or none of these criteria and use this cutoff to guide the treatment. Okay. And in doing so, I think if we have any radiologist on board, they would be happy to know that the studies showed that if we apply this algorithm, we will save a lot, in terms of cost and resources, because we will be able to avoid CT pulmonary angio in 65% of patients if the lady is in her first trimester. So, and 32% if the lady is in her third trimester. So imagine how many less scans will be ordered in the right direction. Okay, the second point we discuss here is once we have diagnosed the PE, what do we do? So the days of, one size fits all have already gone. There is no one treatment for all PEs. Once you diagnose a PE, you need to know what sort of PE is going on. So the recommended classification and prognostication based on the ESC guideline is this. So after you have confirmed the PE, check whether the patient is hemodynamically stable or not. What does that mean? Basically that their blood pressure is stable. The systolic blood pressure is usually above 90. If they are, so a suspected PE with a hemodynamically stable, if they're hemodynamically stable, you can do an echo, and if there is no signs of RV dysfunction, then PE is unlikely. Okay, so this actually is prior to PE diagnosis. So if you are suspecting PE but the patient is stable, you start with an echo. If there is no RV dysfunction, find another cause for the patient's symptoms. If there is an RV dysfunction and the patient is not too unstable, you can arrange a CT angio within 1 to 2 hours. Go ahead with that to reach the diagnosis. If, however, you're suspecting PE, patient is too sick and unstable, or you don't have a scanner at that time, contrast is out of order, something is wrong, so you cannot really do a CT angio, you still proceed based on your suspicion and the positive RV dysfunction finding on the echo, as if that the patient is having a PE, and you proceed with anticoagulation. So the point from this algorithm is that, yes, CTPE PA is the gold standard, but it's not the only standard. According to certain situations, we can rely on the echo sometimes. And this is a grade 1C recommendation that in suspected high-risk PE, as indicated by the presence of hemodynamic instability, bedside echocardiograph or emergency CTPA are recommended for the diagnosis. Okay, so now we'll go through just some cases as we talk. So a little bit of interaction with the audience. So we have this lady, case 1, it was a 60-year-old woman who recently returned on a long flight from Australia, so probably something like an 18-hour flight. And she came to your clinic or emergency with chest pain, shortness of breath. On examination, she had a tachycardia and blood pressure, as stated, is low, and she was hypoxic with a an oxygen requirement of 15 liters. Obviously, you do your examination, there's nothing on the chest, you do the chest x-ray bloods, there's nothing to suggest an infection. You say, okay, this is an acute type 1 respiratory failure. D-dimer probably was high or not. If your clinical prediction rule was high, you proceed with a CT angio. So anybody can comment to us on the CT angio? Yeah, it's very clear, isn't it? Yeah. Okay, so we have the pulmonary trunk, and this is the left main artery, and it's almost like a saddle shape. It's also extending to the other side. So there is a high clot burden PE. Okay, we've diagnosed the patient with a PE. What do we do next? So as you see, 1 to 6 are all possible treatments. You can give heparin, you can give low molecular weight heparin, you can give DOAC, you can give systemic thrombolysis, you can give catheter-directed approaches, you can give surgical embolectomy. I think back then when I was a medical student, the list stopped at 1 and 2, UFH, LMWH, and probably warfarin as well. But over the past 15 years or so, look at the scale of treatment options we have. So then it's a genuine question. What do you do with the patient? Do we take them to the thoracic surgeon? This patient, they're very unwell, isn't it? I mean, their BP is low and probably about to collapse with this amount of oxygen. Do we just, give them maybe heparin? Or... So what will we do? Take them to cath lab. Okay, so yeah, this is a possibility. But if we go by the guidance, so I mean, if we would see the table that we spoke about, so this is defined as a hemodynamically unstable PE, right? So we would agree about that, because the target here is low blood pressure. So systolic is less than 90. So this patient is a high risk PE. What we should do according to the guidance is consider some sort of thrombolysis. And if there is no contraindication for systemic thrombolysis, so given through the veins, we can go ahead with that and supplement it obviously with the standard anticoagulation. Why is that important? Because in some cases of this caliber, if you don't act promptly, this is the cascade that's awaiting you and the patient. There will be more stress on the right side of the heart with more RV dilatation, leading to more tricuspid regurg. This will increase the further tension on the right ventricular wall, more work, more oxygen demand, ischemia of the right side, which means there will be less contractility of the right side. The output from the right to the left will be less. So the left preload will go down, and this means your cardiac output will be compromised. And this is the physiologic definition of obstructive shock. Okay, and if we reach anywhere in the middle of this, we're talking about a very high mortality case scenario. And this has been proven by many studies, including this one from Wood, that the main factor in mortality is the degree of RV dysfunction. Okay, as the RV dysfunction goes up, the mortality goes up exponentially up to 100%. So يعني موت محقق. Okay, so obviously we don't want that. So what can we do? We should classify our patients to the best that we can do. And the suggested classification from the ESC 2019 is this. So just to make things simple, we have 4 main parameters. When you diagnose a patient with PE, you have 4 main parameters. The blood pressure or hemodynamic stability, in brief. What we call PESI and SPECI score as a second point. The RV dysfunction, which we spoke about on the echo. And the markers of cardiac injury, such as troponin. Now, if all of these are present, then we're talking about a high-risk PE. If none of these is present, then we're talking about a low-risk PE, which leaves us in the usually gray zone, the intermediate zone. So if you have 3 of the, so apart from the blood pressure, so if the blood pressure is stable, but the patient has 3 other components of the high risk, then that's an intermediate high risk. That's how you write it. It's an intermediate high risk PE. If he has 1 or 2 of these, you could call it an intermediate low risk. Now, is this important? Yes, because it has prognostic and treatment implications. So just before we jump on to those implications, what do we mean by hemodynamic stability? This is also something I emphasize with my residents and those who are in in the training pathway. It's not really, once again, as in with the D-dimer, it's not just a magic figure, a singular figure at one moment in time. It's any of the following: either that the patient comes to you in a CPR, somebody rolled in with a CPR, and we think during the CPR that they're having PE. So this obviously qualifies as instability. Or yes, that they have a systolic blood pressure of less than 90. And in order for us to maintain it more than 90, we keep them on vasopressors. So they are on vasopressors. And there are signs of end organ hypoperfusion. So we expect this to be severe and probably has been going on for some time for them to develop something like oliguria or AKI. Or that at an earlier stage that their blood pressure is starting to drop. So, but at least for 15 minutes. So I'd say in terms of order, it starts at 3, could go to 2. And if the patient is very unlucky, he could present at 1. So this is all what it means to have a hemodynamically unstable PE. And just a quick, this could probably be better presented by our cardiology colleagues, but what they do when they do an echo? They look for signs of RV failure or RV strain, which is really enlargement of the right side, right to left ventricular ratio more than 1, McConnell signs, a D-shaped straight septum, IBC collapsibility is reduced, etc. So echo is very useful. And in fact, I find this one very interesting. If you see as the drawing is showing us, sometimes during the echo examination, the cardiologist could tell us that I'm seeing the clot in transition in front of my eyes. So we don't need anything else. So as I said, for this patient, who was a high-risk patient, our patient who we were talking about just a minute ago, we should provide them with systemic thrombolysis. There are many agents. Tenecteplase, alteplase was the earliest, and is an FDA approved for this, and this is the standard dosing. Okay. So if we want to give somebody a systemic thrombolysis, is there anything we need to do before that?
Make sure that there is no complication.
Excellent. It seems I don't need to continue the presentation. Okay, so yes, spot on, as we said. So there are absolute and relative contraindications. So on standard, these need to be there with the patient papers, and you need to go through them one by one, tick, 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 no contraindications or contraindication. So if no contraindications, the job is simple. Choose an agent and go ahead with it. Explaining that, though, that there is a risk of bleeding because this is a systemic TPA. It's not a directed. It can go anywhere. Okay. However, the problem is when there are contraindications. So if out of these 6, there's 1 or maybe 2 relative. What do you do? So these are the other options. Surgical embolectomy, catheter-directed treatments, or conservative management. Perhaps the patient is elderly, stage 4 cancer. I mean, this is maybe an expected end. Discuss the ceiling of care with them and, just keep them on heparin, I guess. And the recommendations are all class 1 recommendations. So these are all things to be recommended and done. So for example, it is recommended that anticoagulation with unfractionated heparin, weight-based, should be initiated without delay in a high-risk PE. Systemic thrombolysis is recommended in a high-risk PE. And if that is not possible, we go for one of the other options as a backup. Okay, case 2. Probably a little bit more stable than our first patient. So this is a 49-year-old man who's asthmatic in background, came with a history of 2 to 3 weeks shortness of breath. On examination, there was no wheeze. He had dizziness and chest pain for the past 2 days, and there was no previous DVT or PE in his history. On examination, his saturation is, just sitting on the edge, 93 on room air, but he is tachycardic. Good news is that the blood pressure is okay, and there's nothing really remarkable on the examination. This is his chest X-ray. Anything particular about it? Yeah, so the ECG, absolutely. I mean, and probably an S1, QT3, and maybe also a sinus tachycardia. So classic, textbook possible presentation of, and also these right-sided changes as well. Yeah, so some possible strain if we have cardiology on board. And actually, they did order a troponin, which was slightly elevated. But the chest X-ray per se doesn't show much of pathology. So we proceed with a CT angio. And this is what it shows once again. I think very clear that there is a saddle-shaped embolus. And the second cut shows how the heart looks on the CT scan. So usually this is your left side and this is your right side. Usually in terms of size of proportion, your right side, which is doing the work most of the time, is bigger than the left side. But we obviously see that this is opposite here. Left side is quite probably, if not as big, is bigger than the left side. So there is some degree of strain, we can say, radiologically. Okay, although this is not the modality to diagnose that, we do need an echo. Anyways, so we know the history, we know the diagnosis. We just remind ourselves that this is a borderline hypoxic, but blood pressure stable, so query hemodynamically stable patient. Once again, the question is, what do we do? Do we give them heparin? Do we give them tablets and send them home? Do we give them thrombolysis like our previous patient, or do we subject them to surgery?
This patient has any risk for thrombosis to happen besides obesity?
That's not mentioned. No, he's 49. He's not elderly. No previous DVT or PE. And no, it's just his asthma. So yes, once again, a little bit of a tricky, as you see, people are thinking outside the box, which is something we need to do all the time. But once again, we need to go back to the slide and classify the patient. Where do we think the patient is? So are they hemodynamically unstable? No. There is something called PESI and SPECI score. We need to know about this to say whether it's plus or negative. Do they have RV dysfunction? We've not on the of TTE, which is echo or CTPA. We don't know about the echo, but we do think they have RV dysfunction from the CT. Okay, so they score something here. Have they ordered troponin? Was it elevated? Yeah. So we know that 2 points at least are there, which means even before knowing about the PESI and SPECI, which we'll speak about now, they're somewhere here, isn't it? Somewhere in the intermediate. They can't be lower. They can't be high risk because their blood pressure is stable. They can't be low risk because, for low risk, all of this needs to be negative. And we already know we have 2 positive points, possibly 3, if the PESI or SPECI score is there. So let's go back to that. So we need more details. That's the question before we decide the best treatment for this patient. So we've talking about this. We know already about the RV dysfunction, and the troponin point is quite clear, either it's elevated or not. So what is this column, PESI and SPECI? So these are a group of, once again, it's a very simple questionnaire. The PESI is the original one. I think it has 11 variables. The SPECI, the small s stands for simplified. So it's a baby version of the original one. I think it has 4 or 6 elements. You need to go through all of the elements such as pulse rate, saturation, history of cancer, whatever is there on, and see whether the patient scores a PESI of grade 3 to 4 or a SPECI of 1 point or more. And this is what I was just saying. So this is the original version. As you can see, I think we have like 11 variables. Each is scored differently. And then we're looking at this scoring. Okay, so if the points added up is less than 65, class 1, 66 to 85, and so on. In terms of the SPECI, which we use, or I like in clinical practice, much simpler, easy to memorize, and as we will see in the 2 slides, equally effective. So there's no reason to make yourself suffer with this. It's probably less granular because we have 2 outcomes here. We have more outcomes here, but it doesn't really matter clinically because what I'm looking for in the SPECI is the patient 0 or not. If they're 0, I'm happy. Anything else, they're 1, 2, 3, 4, 5, 6, doesn't really matter. They have a significant 30-day mortality, and I will treat them like high-risk PESI. So 1 point SPECI equals class 3, 4, and 5. All right, so that's very simple. And has this been proven? Are you sure, doctor, that PESI is equivalent to SPECI? Yes, these are the receiver operating curves of both, scores. And as you can see, they are identical on the graph and in terms of positive and negative predictive value. And that's on a 50,000 patient study. Okay, so for our patient, if you calculate their SPECI, it's 2 because they have asthma and they have tachycardia. Okay, so now we go back to that. I think this is the most important slide. This is really the most important slide for those who are going to treat these patients. He has a SPECI of more than 1 or more than 1. So that this is positive. He has a RV dysfunction and he has an elevated risk. So he's intermediate high risk. So we classify this as intermediate high risk. Does that matter? Yes, because this will tell you what to choose in terms of treatment. But before we answer the treatment question, as you see, it's beginning to get more complex, isn't it? So it's not really just the PE scan, start heparin and go and sleep. No, it's echo, it's comorbidities, as we saw on the original PESI. I mean, we probably didn't go through that, but if you want to go through that, look at what we have. We have age, male, cancer as a comorbidity, heart failure as a comorbidity, COPD or chronic lung disease. This patient has asthma, for example, so that scores a 10 point. Pulse, blood pressure. So it's quite extensive. Okay. And yeah, based on this score, we say this is intermediate high risk, and we would start him on anticoagulation, so heparin or low molecular weight, but with a very low threshold to give systemic thrombolysis. So on the first case, we went directly with systemic thrombolysis. In this second case, the guidance is systemic thrombolysis should be considered as a backup plan. Everything should be ready next to the patient in an ICU, monitored setting, doctor available. Once we think that the trend is going left or north, as they say in England, that means things are not good. Let's proceed with the thrombolysis. What recommendation is this? It's a 1B. So it comes from one randomized controlled trial. Rescue thrombolytic therapy is recommended for patients with hemodynamic deterioration on anticoagulation. So such a patient on heparin and is deteriorated, I should consider thrombolytic therapy as a risk. Now, this is exactly what I said, but I think in the graph mentioned and the guidance actually. So just briefly, patient with acute PE, you anticoagulate and you check their hemodynamics. If they are unstable, then you have to proceed with some form of thrombolysis. If the blood pressure is stable, you need to check whether they're intermediate risk or intermediate high, intermediate low, or low risk. As we said, that is based on the markers, on the TEE, on the echo finding, and also on the PESI and SPECI. And then if you have 3 points, that's intermediate high. If you have 1 or 2 points, that's intermediate low. If you have no points, that is a low risk PE. Is it also important to know that the patient is a low risk PE? Yeah, very important. And some of us will be happy to know why it's important. Okay. So, but anyways, back to the slide. It just tells you about the amount of things we need to factor in to compute and reach to the final answer. Okay. So as if this is not enough, there are suggestions that in addition to this, lactate could help. Doppler ultrasound of the legs could help, and NT-proBNP could help further give us granularity in terms of deciding which group the patient is. So for example, this is one study that is talking about lactate. Can we use lactate, lactic acid in the blood as a marker of bad prognostic signs and PE? And the conclusion is simple. What is the bottom line? Plasma lactate measurement represents a powerful method of predicting short-term PE-related complications. Short-term, so death, recurrence, cardiovascular collapse within the first 7 days are possibly associated with a higher lactate. And this is the graphic representation. So this is a patient who has lactate that is high, and this is our patient who doesn't have a lactate high. And look at the difference in magnitude of complications, probably double. Once again, these are not in the guidelines yet, but we expect them to be incorporated. Okay, so lactate is one of them. Another one of them is the presence of DVT. So if you have somebody who has a PE, does it really matter if they also have a DVT, or we don't need to look for that? No, we need to look for that because this increases the odds of an adverse by 4.7. And if you go through all of the known other odds ratio, this is the highest score. So 4.7 for the presence of a DVT compared to 2.9 for immobilization, which is still high, but not as high. 2.5 for cancer, still high, but not as high. And not only that, the most significant in terms of clinical significance is once again the presence of DVT. And this is completely absent in a lot of practices. Once we diagnose DVT, sometimes we don't look at the CT angio, or vice versa. Once we diagnose CT angio, we don't really look at the Doppler ultrasound because we say the treatment is the same. Correct, the treatment could be the same, but the outcome might not be the same. Okay, this is just a brief about certain studies that talk about the cutoffs. So for example, the cutoff for BNP is 100. So in the setting of PE, more than 100 or less than 100 tells you whether it's a positive study. And for troponin, it's not like the cardiac insult. It's not, I think, the normal reference rate. It's actually 0.05. So any slight elevation in troponin is a positive on the table I showed you. Okay, so this is more of the same, really. Just suffice to say that if you take all into account, okay, so this is talking about each individual element and how much it increases the odds ratio. So if I have a troponin positive, it increases the ratio of adverse events by 10%, DVT by 9%. How about if I have a combination of both, of all? If I have a high risk PESI, the score we spoke about, and troponin and RV dysfunction, it increases the odds of negative adverse events by 20%. But which is the highest of all of them? If you actually combine a high-risk PESI with a right ventricular, strain and a DVT. So once again, this DVT element is completely missing, and we expect it to come heavily in the upcoming guidelines. And if they do that, this is, something, I've predicted. It's not there. They don't quote me for this. That if you compare this to the previous, the ESC actual, risk classification, I've added one column, additional adverse features. So I suspect that some of the things we spoke about, the lactate, should be added and factored in. So instead of talking about, just these 1, 2, 3, 4 elements, probably there's space for more elements. And if we do that, we could probably further divide the intermediate risk from intermediate high and intermediate low to intermediate high, intermediate middle, and intermediate low. Okay, so just an approach to thrombolysis and intermediate risk PE. So if the patient has an intermediate risk PE, and I am sure now we're familiar what that means, what do we do with them? We take them to an ITU or HDU, we give them heparin, we consider Doppler ultrasound, serial echo, so not just echo, serial echo. You might do it on day 1 and then on day 2 or 3, depending on the need, and serial biomarkers. And then either transfer or at least have a connection with a center that can provide catheter-directed approaches. Because maybe at 12-hour margin, the intermediate low becomes an intermediate high risk, or the intermediate high becomes a high risk, actually. BP goes down. What do we do then? We consider thrombolysis. So you need to have everything streamlined and ready to go at the click of a button, actually. And this is what we're trying to work on around and changing the PE practice in this country. So consider thrombolysis. When there's clinical worsening, you find a DVT with the PE, lactate or troponin is going up, and the patient is a young age. Why patient young age? Because we expect them to be able to take the toll of thrombolysis with less risk of bleeding, as opposed to a gentleman who's 70 or 80. Okay, and what recommendation is that? Rescue thrombolysis is recommended for patients who deteriorate hemodynamically. It was a 2A in 2014 until further studies told us this is unfair. This is actually a class 1. We should do rescue thrombolytic therapy for patients who deteriorate hemodynamically and the intermediate risk PE we're talking. And this is the base of that evidence. Look at how many studies we have. So the most important are the MOPET and possibly the PITHO. The PITHO study, which was in 2014, studied really 1,000 patients of intermediate risk PE and told us that is there a place for thrombolysis in intermediate risk PE? And the answer was yes. So the outcome of that study is this. We said 1,000 patients, half in the thrombolysis group and half in the placebo group. Placebo obviously does not mean we did not keep them on treatment. We gave them heparin with placebo. So they were on standard treatment. So standard versus thrombolytic and heparin. Was there a difference in outcome? Yes. At 7 days, the all-cause mortality was 2.6 in the tenecteplase, so the intervention arm, more than double that on the placebo in the started treatment, 2.6 to 5.6. This is middle-aged, young patient. This really makes a huge difference. Okay, even one life, even 1% difference makes a difference. But unfortunately, not everything is romantic. So this came at the expense of a higher risk of bleeding. So you save more from the PE perspective, but you have more risk effect, side effects in the terms of bleeding. So suffice to say that the bleeding is either major or moderate. So as you can see, the figures talk for themselves, 16 versus 2. And more worrying is that some of the bleeding actually occurred in the brain. Hemorrhagic shock, 10 times more common with tenecteplase versus placebo. So the question is back to us. Do we give thrombolysis or do we not give thrombolysis? Do we save the patient from the PE or do we subject them to a 10-time higher risk of bleeding in their brain? Okay, so they might live for another year on a ventilator. So that was the conclusion, unfortunately. And based on that, in clinical practice, giving thrombolysis in this cohort of patient is not a standard. It's a case-by-case discussion. You need to explain to the patient that this is the risk from these studies. If they are happy to sign, and the moment arises that they deteriorate, that's one thing we can do. Just proceed with the systemic thrombolysis and hope he's one of the lucky ones who has a good outcome with the PE without a complication. Okay, other studies are talking about, so we have PITHO2 and PITHO3 as well. In terms of time. Okay. PITHO3 is taking it to another level. So in the intermediate high-risk pulmonary embolism, is there any chance for giving a reduced dose thrombolysis? So some people are thinking even smarter. So based on the PITHO1, there was an effect, if you remember, but there was a side effect. So these guys in PITHO3 said, okay, is there a way to increase or maintain the effect, but reduce the side effect? Possibly. by reducing the dose. So they want to use the same thrombolytics, same approach, for same patient cohort, but at half dose. So let's say if they were giving thrombolysis of 100, they want to give maybe 50, and see if that leads to the same, reduction in mortality without causing the bleeding side effects. And actually, I can say in clinical practice, I like this approach. I've used this approach, and many of my colleagues as well have used this approach. And we do think that the outcome of the study will be positive. Yes, there is a place for half dose or modified dose. This is an ongoing trial. We don't have results yet, but this is from clinical practice. Obviously, when we use this, we consent the patients and speak with them that, this is not exactly in the guidance, but the guidance tells us to consider thrombolysis. Which sort of thrombolysis? We prefer the half-dose thrombolysis. Okay. And this is the design of the study. We don't need to go through it because, as I said, study completion date is 2027. So let's hope all is well until then, and we'll see. Which leaves us with the interventional management. We've spoken about the heparin, the thrombolysis systemic, and then there's an arm of interventional management. So if we have interventional radiology here, they can perhaps give us a more elaborate lecture at one time about this, but this is in brief. So when we have an intermediate risk patient who cannot receive thrombolysis, or a high-risk patient who cannot receive thrombolysis, or they received it and it failed, what do we do next? We'll either have the big window here of doing a major surgery plus minus ECMO, or doing catheter-directed approaches. I call them CDTs, catheter-directed treatment approaches, rather than CDT as thrombolysis, because it's not just a thrombolytic agent that we can provide through the catheter. We can provide ultrasonic fragmentation. We can provide saline agitation, which is called rheolysis. We can provide thrombolysis, and we can combine, provide so it's not just giving a thrombolytic agent. You can actually lyse the clot with some high ultrasound waves. You can push a high pressure saline agitation, lyse the clot if it's fresh, and just aspirate it. And these are the different, available. ECOS is the most studied, of these, and it's a combination. It's a hybrid method. So it gives high ultrasound waves to lyse the fibrin strands, and then it makes it easier for your thrombolytic agent to just, dissolve the clot. And this is perhaps out of all of these systems, the only one that's studied really in a few RCTs. So it is evidence-based. It is approved in Europe and the States, I think, for this purpose. And this is the protocol they've done in the Ultimate trial. So they talk about, giving the ultrasonic waves followed by RTPA at this dose for around 15 hours. And once, your echo and the hemodynamics are stable around, 10 to 15 hours, you can discontinue the infusion through the echoes and probably remove the catheter. So it will stay with the patient as an implanted device for probably 1 day. Their study proved that this, compared to just standard treatment, was actually effective in reducing the strain on the right side. Yeah, so let's see. So in the ECOS group, the strain went from 1.28 to 0.99 versus almost no change in the standard group, without any increase in really risk of side effects. So what does this tell us? It tells us that there is a consensus or expert opinion, not really exactly a class 1. So it's a C, expert opinion, that yes, there is a place for catheter-directed, methods in high-risk PE who fail thrombolysis or are contraindicated for thrombolysis. You can go for a catheter-directed approach. And putting all of what I said into context, this is what they suggest. So just briefly, if you have a high-risk PE, you'll start your anticoagulation and subject the patient to systemic thrombolysis if no contraindication. If there is a contraindication, you can consider a catheter-directed treatment. Okay. If it's an intermediate high risk, you will start with anticoagulation, and this might be all that's needed. So success, we go here. We don't need systemic thrombolysis. We don't need a surgery. We don't need a catheter. This is what happens most of the time. However, as we said, there is a chance of deterioration in this gray cohort. Here, you can consider half-dose thrombolysis, or if there's a contraindication, once again, go through a catheter-directed approach, which, by the way, needs to be started early. So within 2 to 4 hours after you've made the call of systemic thrombolysis. So that means You give the systemic thrombolysis, the patient is on a cardiac monitor, and you are measuring their blood pressure minute by minute, hour by hour. And up to within 2 to 4 hours, you should start to see a response. If you don't, you're worried about your young patient who you're losing in front of your eyes, you think it's time to declare that the thrombolysis has failed, this is your second best chance to make him survive. And then finally, there's another ongoing trial, the high-PITHO trial. So they're talking about, once again, using these ultrasound catheter-directed thrombolysis versus anticoagulation and the intermediate high. So that study was by the company. The ECO study was by, I think, the company. This is now a real-life study, and let's see the outcome of this. I think it's probably coming next year. Okay. So what will the trial tell us? Is expected to inform guidelines and set the standard for evaluation of catheter-directed reperfusion. So as you can see right now, it's a little bit of a gray area. Do we give it before half-dose thrombolysis, after half-dose? Do we wait for 4 hours? So things are probably not set at 100%, but this study and other studies is supposed to help us answer this question. Okay, so case 3 takes us to probably our last case. So this is a 54-year-old man who was breathless for 1 week and came to the clinic with pleuritic chest pain on breathing. He has no risk factors for PE, no antiphospholipid, no cancer, no previous DVT, nothing, no obesity. His vitals, as you can see, are absolutely fantastic. His SPECI is once again 0. If you remember the 6 score, it's 0. Echo or probably CTPA shows no strain on the right side, no RV dilatation. Daughter getting married in 3 days. Not sure if that's relevant. Maybe it is because he needs to get home in time. No current medications, and he lives with his wife and is otherwise fully active and independent. So where do you think this patient will lie in our, in this table really? I can't maximize it now, but no risk, because is he hypotensive? No. Does he have a SPECI of 1 or more? No, the SPECI is 0. Is there strain on the right side? No. Is there elevation in the troponin? No. So he's clear. He's green. Is that useful? He still needs treatment, isn't it? Yeah, it is useful because we'll tell you that this man will probably make it in time for his daughter's wedding. Why? Because the guidelines say if you have a low-risk PE, such as this one, in the absence of aggravating comorbidities, so nothing major, and there is an infrastructure to deliver outpatient care. What can we do then? We can actually discharge the patient. Carefully selected patients with low-risk PE should be considered for early discharge and continuation at home if proper outpatient care is managed. So I know this is not a class 1, it's a 2A, but 2A means should be considered. So this is the same thing. So there is an arm of low-risk people in the right setting. So in like the NHS, for example, they have outreach clinics. So if I see a patient who's low risk, I discharge them today. Tomorrow, by standard, there's going to be a nurse or a specialist calling them, asking them, is everything fine? Your blood pressure is okay. Do you need us to send a nurse? Are you, having hemoptysis now? Should we admit you? Just making sure everything is fine for the first week. And then the story ends there that he will carry on until 3 to 6 months of treatment. He never had to be admitted. All he had to do is get a proper evaluation according to this table. And he went home and he enjoyed his life and attended his daughter's wedding. Okay, so keeping all into context, this is the same thing. It all starts with the diagnosis, hemodynamic stability, unstable. This means it's a high risk. We need some sort of reperfusion. Stable, we need to classify based on the SPECI, troponin, RV dysfunction is this. So if none of these factors are there, it's a low risk, could be discharged. We're not saying discharge always, we say could be discharged. But that's a good, for volume loaded centers, we don't have a capacity to admit everybody. This is a good possible option, but you need to follow them up. And then the intermediate risk, of which I think we've spoken enough about. And then I think the last 2 or 3 slides, is there a risk of PE coming back, recurring? Yes, some of this pertains to the duration of use. So depends on how long we treat the patients. Do we treat them for 3 months, 6 months or more? So extended use or not? Do we treat them with vitamin K antagonists, which as you know is the other name for warfarin? or the DOACs? And also, in what context did the PE occur? So we have three graphs here, okay, 3 lines, sorry, about patients with PE who were diagnosed with PE, and they were followed over time, month 4, 8, 12 to 24. And they were on treatment, the recommended treatment. So the first line in blue is somebody who had a PE with no identifiable risk factor. So at this point, when I diagnosed them with PE, I couldn't explain why they have PE. They hadn't cancer, no previous PE, no antiphospholipid, nothing, but they have PE. So no identifiable risk factor. If we give them standard treatment and follow them up, their cumulative proportion of risk of recurrence, as you see, goes up after, a few months of treatment, goes significantly up. So almost 20% of them will have a PE again. If the PE occurred in the context of a transient risk factor, I would say a transient mild risk factor, this is the curve. So it goes up, but not as significantly. And if the patient has a major transient, like a major surgery lasting more than an hour, admission for 7 days in hospital, etc., so a major transient, and that was removed, the risk of recurrence, I think I can see it. I think it's this dotted line. It's almost negligible. Does this tell us anything? Yes, it tells us that when you diagnose a patient with a PE, you need to see which context they are. Was there any risk factor? No risk factor? Major risk factor? Mild? And you need to factor that in your treatment recommendation. So for me, if this is what the data says, and I know that there's going to be a recurrence, and if I stop the treatment, the patient might come back to me at this point or this point with another PE, major PE, I probably will not be happy just to stop treatment after 3 months. I would rather that he be on the treatment for as long as possible without complication, being monitored, albeit maybe every 3-4 months in my clinic, that's fine. But I would not want to subject them to this compared to this. I mean, all lines should be here. There should be no recurrence because we should have treated, identified the risk factors, and removed them. But if that was not possible, then we need to keep them on probably longer, So this is just a point to reflect on. Do we stop everybody at 3 months? No, it depends on this context because we're worried about recurrence. This is the same. So when you treat patients with the warfarin for 18 months and then stop it compared to placebo, at this point the risk of cumulative risk of recurring PE starts to go up. So this tells us that probably even 18 months is probably not enough. So but what the guidance actually says in the manuscript is this, as it depends on the risk of long-term recurrence. So they divide it into low risk, so that's less than 3% per year, intermediate risk 3 to 8%, and high risk more than 8%. So what's the high risk? It's any patient who's diagnosed with PE and having an active cancer. They are likely to have be on the higher side of cancer recurrence. So that's a high risk. Intermediate risk is any of these. So somebody with a minor surgery. What is a minor surgery? So anybody subjected to GA less than half an hour. Admission to hospital less than 3 days. Pregnancy. Okay. And then what is a major risk factor? No, surgery more than 1 hour. Confined to bed more than 3 days. Okay. So based on this tells us the risk of recurrence. And then these are the recommendations. So if you're a low risk, they are happy for you to, for patients with major and reversible risk factor, discontinue treatment at 3 months. We're happy to stop at 3 months. For the other guys, intermediate or high risk, most of the recommendation you will see is about indefinite treatment, actually. Indefinite means probably lifelong. So extended oral anticoagulation of indefinite should be considered for patient with first PE and no identifiable risk factor. And to be honest, if I tell you of the amount of PE follow-ups I see in my clinic and people not really adhering with these recommendations, it's quite really a pitfall, really. A lot of people are still just going for a universal 3 to 6 month for everybody, which is absolutely not the way. Okay, so either there is a no identifiable risk factors, which means maybe this patient is thrombogenic. We don't know what the risk factor is. We shouldn't really stop the treatment at 3 months. Just give them. All right. Okay, so I think I've delivered the messages I want. Yeah, we can stop here for questions or discussion.